Sure. So it's a great pleasure. This is a historic moment for us because this is the first webinar of the Young Neurosurgeons Forum, a committee that comes from the World Federation of Neurosurgical Society. And we're really honored to have our first speaker is the president himself, Professor Franco Servadei, who is a professor of neurosurgery in the Humanitas University and Research Hospital, Milan, Italy, about global neurosurgery and integration regarding to head injury. Now, one word about the webinar system and the Neurosurgery Forum. We plan to do this once a month. It's supposed to be very educational. We will strive to invite who can build on the knowledge of the trainees, and even afterwards we can have more. However, we will start with once a month, and it will be announced on the social media, on the website, on the email list, on the WhatsApp groups, and on the Upsurgeon application of the mobile smartphone. So I'll leave the floor for Professor Servadei.
Hello, it's also my pleasure to be the first speaker in this series that we believe it will be long and with many topics. The Young Neurosurgical Forum is working hard to get more audience all around the world. And we all think that this is mostly appropriate. We need to improve the education within the WFNS, and we need to improve the education, especially for young neurosurgeons. So just to tell you what we will be talking about, the World Federation of Neurosurgical Society has a project that we call Global Neurosurgery, when we involve many other authorities. And we may have in the future another presentation concerning the Global Neurosurgical Project, including the connection that we have with the World Health Organization, and including the project who is leading in Cambridge now about the global neurosurgery improvement all around the world. So at this first presentation, I will discuss with you about how do traumatic brain injury interfere with the issue of global neurosurgery. The World Federation of Neurosurgical Society consists in 5 continental associations, 119 societies all over the world, and 6 affiliated societies, plus 5 continental associations. In practical, we are 45,000 neurosurgeons all around the world. And the worldwide neurosurgical scenario, it's actually what we see in the population in the world. This is a table showing you the expectancy of life all around the world. And you see that whereas there are countries like, let's say, Japan here, Australia, Italy, France, Spain, Canada, where the expectancy of life is over 80 years, there are many countries in Africa, but also you see it here and there in Eastern Asia, where the expectancy of life does not exceed 50 years. So there are huge disparities between the possibility of the health to conduct a reasonable life until 80, 85 years in some countries, but not passing 50 years in many other countries. So these disparities are shown, as you see. This is a map of the world according to the number of general surgeons that we have. You see it here that Africa is almost non-existing, whereas this is my country, this is Germany, this is Japan. Some countries are hypertrophic. So you see that even the number of general surgeons per population represent a good scoring of the availability of physicians all around the world. And this is evident in neurosurgery. If you go to the website of the World Federation, the WFNS website, and you click on World Neurosurgery Workforce, the Professor Key Park at Harvard University has included for each country the number of available neurosurgeons per population. And you see it here. If you click over like this, you will see that, for instance, in the United States, there are 1.6 neurosurgeons per 100,000 inhabitants. So it's more than the WHO target, which is 1 in 100,000 population. In Italy, we also have more. We have 1.5 almost. In China, they are actually 0.8, very close to the target. In France, is only 1.6, 0.6. And if we go down to Argentina, where we have 0.5, to India, where we have 0.27, means 1/4 of the neurosurgeons who are needed in India. And then we go to Congo, where the neurosurgeons are really 0.000 and something. So you see that the difference between countries with more neurosurgeon and those with less neurosurgeon is even as high as 10,000 times. We have just published in the last number of Journal of Neurosurgery a paper on the current capacity and the provision of essential neurosurgical care, which is the concept of global neurosurgery. This paper was obviously written by our colleagues at the Harvard Medical School, but it contains also Graham Figan as an author from South Africa, Miguel Arraiz from Spain, myself from Italy, Frederick Boop from US, Walt Johnson from US, but representing the World Health Organization, and Benjamin Worf from US, but working in Africa. Sorry. This is what we have done is an electronic survey with 200 neurosurgeons from more than 50 countries, which were asked to estimate the proportion of neurosurgical disaster that they will treat. This was a typical case volume and type of cases which represent the world. So as you see, the estimation is 14 million new operations in neurosurgery per year, which most of them are done in Southeast Africa, Asia, and Western Pacific. Very few are done in the United States or in Europe, where we will see most of the papers come from. And most of the surgery are done for emergencies. Very few surgeries are done for other reasons. If we look at it from a worldwide perspective. But even in Japan, as you see, this is a division of 239,000 procedures in 2014 in Japan. 23% are done for trauma. About the same are done for vascular surgery and brain tumor and others. And if we go to Europe, we know that between 15 to 35% of the surgeries are done for emergencies. So the emergency at the brain and spinal injuries are important in this worldwide scenario. And this is a complicated table, but you can see it here. If we have about, in the world, about 70 million treatment, out of these surgeries or treatment for TBI, 50 million are in low and middle income countries. So most of what we do in the world is not done in high-income countries than in low and middle-income countries. So, which is the epidemiology of the brain injury as an example of a global approach and how life is different in different parts of the world. So we know that in Europe, this is a European paper, but it's the same in US, Japan, Australia. There is a change in the population of patients with traumatic brain injury. The average age that you see here change from 25 years in the 80s to about 45 years now. So it's 20 years incremental. And you see here that falls have now surpassed road traffic accidents. So we have in Europe older patients, and fall is the first cause of injury, as you see it from here. And this is a paper from ourselves, which shows you that with the years, the number of young people having car crashes, so this was moped crashes, decreased tremendously with the use of a crash helmet law. So we got less and less young people with a traumatic brain injury, and we have here more and more older people. So our population changed. And this is a Japanese paper showing that patients over 65 years have a very high comorbidity. In particular, these patients, most of these patients are anticoagulants and antiaggregants, and this makes the trauma by itself more severe. You see it here, this is a typical patient of ourselves, 71 years old with the Glasgow 14, which comes from this small subdural, acute subdural. The patient is under clopidogrel, the coagulation is not good, and within a few hours, the hematoma increase, and we also have the appearance of a parenchymal lesion. So this patient shows you that the typical population in Western countries are older patients with a drug assumption. But we know that if we look at 2030, in the world, the traffic injuries will be the 5th cause of death. So how is it possible? I have shown you that in our countries, road traffic accidents now are passed by falls as the first cause of injury. This is why you see that there's motorization with no protection at all, very often, or like here. So we do have a really high risk of injuries in countries where there was no risk of injury before the motorization. So if you do have an injury without protection, you have an epidural hematoma, which is a contact injury. And we have shown that when we use the motorcycle helmet law, this hematoma disappeared. So what we have in the world is two different parts. One part in developing countries where the trauma is due to road traffic accident, and we do have more epidural and more acute subdural hematoma as the first cause of trauma and as the first hematoma. Whereas in our areas, the population is older, falls are the first cause of trauma, and we do have more comorbidities, more contusions, and more chronic subdural. So these two populations, as you see, they both have traumatic brain injury, but this population is completely different from this population. So, and this, it's on the contrary, who is publishing? Who is publishing in our journals? These are the 12 top journals in neurosurgery, and you see that most of these papers come from high-income countries or high middle-income countries. So most of the papers who are published, almost all, come from countries where the population of trauma is completely different from these countries, where the publication you see are very few. So we do have in this area of the world, we have the injuries in young people, and in these areas of the world, we have the publication. So the publication are on one side, the traumas are on the other. And these are the countries most publishing. You see that only India can be a country where can be scored as middle-low income countries. So only India. All the other countries are not there. So we have to consider that the development of guidelines or anything which is evidence-based is provided only by these countries, where there is no lower income country. So, and another example is how do we deal with the resources that we have? You see, these are guidelines recently published by our American colleagues about the management of traumatic severe brain injury. And as you see, we do have guidelines produced in a context of high-income countries. It's not produced in a context of low and low-middle-income countries. So these are guidelines produced by these countries, basically, we think, appropriate for the same countries, but not for the other ones. If we look at the ICU that I had when I was in Parma, this is a typical Western country ICU. One nurse, one bed, a lot of nice monitoring, everything going. And we published guidelines about transfer of patient to neurosurgery together with our American colleagues. And we show that with a proper guidelines and a proper protocol, with telemedicine, we could treat most of our traumatic brain injury patients outside neurosurgery. And the outcome was similar to the one we had by concentrating patient to neurosurgery. But you need what I showed you, a guideline, a protocol, and a telemedicine system. But if you are in this part of the world where you don't even have enough ventilators to treat these patients, then the situation is different. How can you think that this patient can be treated in the same way as these patients? Maybe we need to stratify priorities. We need to use guidelines applicable to the situation in which you are. And basically, guidelines must be related to the locally available resources. At least we must all refer to national or international guidelines, but make them applicable to the reality where we work. And just to tell you about one type of brain injury surgery, which we work since many years, we are working on this, on the cranial decompression. And we have recently worked on a project, which global project. We had a meeting in Cambridge recently about how do we deal with decompression in countries with limited resources. And you see that this is a paper from the Cambridge group showing that decompressive craniectomy have a very good effect on intracranial pressure, very good effect on cerebral perfusion pressure, but these are index a bit complicated, but not so good effects on autoregulation. And this is a paper of ourselves showing that the brain, the CBF on the side of decompression increased tremendously after the operation. And whenever you have contusions here, that may be a problem. So which are the techniques that we use? Basically, there are two techniques. One technique is a bilateral bifrontal decompression, which was popularized by Pauline, but it has been written first in the 70s by the group of Schellenberg and Prieto. This technique is mainly used for secondary decompression now, decompression driven by ICP monitoring, whereas this technique is the usual unilateral frontotemporal parietal decompression, and this can be used for primary and secondary decompression. We will see the difference. This is the guidelines that were recently published. The guidelines say that if you want to decompress a patient, you need to use a big bone flap, 12 or 15 centimeters of diameter. We say even 12 to 12. And that's extremely important, because if you don't do that, you get the complication related to decompression, which is mainly what we call in Latin fungus cerebri. So the brain is pushing along the bone edges to come out because of the pressure, and you get here closure of the veins with a disaster like this, meaning a brain infarction related to the closure of the vein at the edge of a too small bone flap. So whenever you want to do, this is a Chinese paper comparing these two decompression and showing that this is far superior. And we also have in a paper of ourselves demonstrated on 500 cases, demonstrated that a bone flap over 12 centimeters, even in a multivariate analysis, was a determinant of outcome. So if we want to decompress a patient, we need to do a big bone flap. And there is the only you have to start surgery with a large flap. Then this is a slide that I have from the courtesy of the group of Cambridge. We do have an ongoing study, which is on primary decompression. As I told you, primary decompression is for acute subdural hematoma, for instance, and is an hematoma evacuation plus bone decompression. It's called primary because it's not driven by intracranial pressure. It's driven by the image and the clinical. It's driven by radiological and clinical examination. The patient is worsening. The CT scan shows you a huge acute subdural hematoma. So your feeling now is to evacuate the hematoma and decompress. And as you see from papers that were recently published, 1/3 of the patient with a severe traumatic brain injury have an acute subdural hematoma, and more than half of these patients, whenever you evacuate the hematoma, the patient is also decompressed. And the Cambridge group has organized a multi-center trial that you can join, which is called the Rescue ASDH trial, acute subdural hematoma, which randomized the patient with an acute subdural hematoma to craniotomy only, meaning evacuation of the hematoma, or craniectomy and evacuation of the hematoma, meaning evacuation and hematoma, and the bone is left out. Until recently, there were 329 patients enrolled. And as you see here in this, which is available on the website, the most recruiting center is in India. It's NIMS, which tells you about the number of patients that there are in this country as compared to the number that we have in Europe, which are much smaller. The TECRA study, which is a study published in 2011, this study includes patients with an ICP over 20 millimeters of mercury for more than 15 minutes up to 1 hour period. In most parts of the world, these patients are not decompressed. So when we do A clinical study, the first question that we have to ask ourselves when we organize a clinical study is how close is this study to the real life? How close is to our daily routine procedures? Because this study included a group of patients which is very rare and is not really the one in which we target decompression. But nevertheless, there is a big teaching in this study. When we decompress the patient, the intracranial pressure went down to 15 millimeters of mercury, so almost normal. But as you look at these slides, you see that the number of patients who died was the same, but the number of patients in vegetative state was much increased as compared with standard of care. So what we could say that the patient treated without decompression with this indication, diffuse injury and ICP over 20 for less than an hour, did not work. So the biggest teaching in my view of this study that ECP alone is not an indication to decompression, because you see it doesn't work. Even if you reduce the patient, the ICP, to normal levels, then the patient's outcome are not good. So it means that there is a multifactorial treatment of our patients. We all know that ICP, we need to monitor ICP because the treatment of severe head injuries is the treatment of the intracranial hypertension. And to treat intracranial hypertension, we use a staircase like this, where we go up to the last point, where is decompressive craniectomy. And you see that you have different steps, and each different step is identified by a value of the ICP. So we start with, let's say, increased sedation, and only if the ICP increase, then we use CSF drainage and so on. So without ICP, we cannot treat this patient in the proper way. But we have not been able to demonstrate that ICP alone is monitoring of ICP alone is able to better the outcome of these patients. And this is due to the fact that our patients have a complex pathophysiology, and we only, as surgeons, for instance, we use a multi-parametric approach without discussing about the multimodality monitoring and everything we can do with our patient. But if we talk only about ICP, clinical and radiological deterioration, you see that they are equal in deciding in favor of against surgery. So we know that if we have a patient like this with a small contusion and we place an ICP monitoring, ICP goes up, contusion enlarge, and the patient worsen, then we operate. But if this contusion will be the same here, there will be no change in the contusion. Do we operate only on the basis of ICP? I think no. So we need an approach which in the most simple way is a combination of physiology, ICP, clinic, GTS, and radiological findings. The rescue ICP, it's the study which was conducted in Cambridge and published recently. And this is a different study, is a study about rescue decompression, so do the decompression whenever all the medical, except barbiturates, all the other medical management failed. And this is the paper, and you see that this typical patient to be included in the study. You see it here, the two contusions, the intracranial pressure was controlled by medical means until day 6. Then it went up to 40, and we did a CBF perfusion, and there was no perfusion, almost very little frontal left perfusion. So we did a large decompression with good results. So this is a typical case of a secondary decompression, decompression driven by ICP. The study was conducted mainly in Europe, with 70% of patients included in the UK. And this study is much closer to reality. I mean, these patients are in our hospitals are very frequent. These are, unfortunately, they constitute the worst part of our job. These are patients with ICP over 25. The options for treatment are here: ventriculostomy, mannitol, diuretics, hypothermia. Then if you don't control ICP, you randomize patient to medical and surgical treatment. As you see it here, the patients really, there was a number of patients we did a crossover, which were treated with medical therapy and ended up to a surgical group, but not many of them. And these are the outcomes, meaning that if we look at the medical and surgical group, there was at 6 months a very important difference in the number of people who died. Unfortunately, there was an increased number of people being in vegetative states and lower severe disability. And if we consider good outcomes, they were more than in the medical group, but not to a statistically significant meaning. But the situation changed after 6 months, and you see that after 6 months, quite a number of patients shifted from low severe disability and vegetative to better results. And then the P became significant. What does it mean? That from 6 to 12 months after injury, extensive rehabilitation and the surgery, which we do after the first surgery, meaning late surgery like cranioplasty, treatment of hydrocephalus, produce results, produce better results here. And as you see, the treatment of a severe TBI patient is very long. And you see that this patient needs a treatment in acute phase, but also treatment in late phase and social integration. The cost for this patient is very high, but we know that to follow this scheme for 12 months is not all over the world, because you need social insurance, which covers the treatment for 12 months. And this is only in few countries in the world. So just to tell you how is it, this we think from the results that we have that decompressive craniectomies, as I have shown you, is done either as a primary surgery or driven by intracranial pressure later. This is always in severe head injury patients. But this is Nigeria. This is a paper in which they write that they cannot repeat CT scan because of money. They can only do one CT scan. So whenever they have a bad CT scan, then they go directly to decompression because they don't have time to wait and repeat CT scan for days. They don't have proper ICU management, so the decompression is the easiest way to do it. So around the world, there are different approaches to decompression. But there is one question that we need to speak about. In countries with limited resources and with patients living hundreds of kilometers far, the reconstruction with the cranioplasty like this is difficult and is expensive. So in many countries, the problem of the decompression is not the decompression itself, is the long-term reconstruction. And so there have been some proposals how to avoid it. This is the concept of hinge craniectomy. which in the Indian version, you see it here. You split the bone and you leave the bone like this without taking it out as we usually do. You leave it there, but disconnected in the way in which you can reduce intracranial pressure, and then it goes down and it takes again its place, at least we hope. And the other issue is the cysternotomies, which is another operation which can avoid completely the use of decompression. There are some, as you see it here, some pathophysiological possibilities to explain how does it work, but this is only a possibility which is reported in the literature. And there are quite a few number of case reports with the long-term follow-up of this surgery. So we have nothing against this type of approach, but as you see it from here, from the comments to this study, you see that the question is not every neurosurgeon who is in duty is able to perform this procedure. And second, at the moment, we have not yet received an evidence based about this. So a new technique is proven when in a controlled randomized study, it is demonstrated to be superior to the standard of care, So even if this technique is new and promising probably, but we need to have evidence in a nice perspective study, we need to have evidence that does it work. In conclusion, I would say that as you have seen from this, decompressive craniectomy is used in many parts of the world in different ways. And this is the first statement that I want you to catch up. The same surgical approach is not the same all over the world. Indication may be different. In Western countries, we need first to cure our patients with other measures, medical measures. So you see it here. This is a study done in Milano in 4 units, ICU units in Milano, and there are 400 patients with traumatic brain injury. And as you see here, only 18 had a decompressive craniectomy, means 4.4%. We published in 2012, 5.3%, about the same. And Arabi in Shock and Trauma Center in Baltimore published 5%. Albanese is in Marseille in France, 5% again. So we know that only a very small minority of patients will be submitted to decompression. But this is, if we look at what is going on in most part of the world, is not the same. This is US, and you see that in these centers, craniectomies were constituted 75% of traumatic brain injuries enrolled in these studies. So there is a huge difference in the numbers of patients. So which are the good candidates for decompression? Basal cistern effacement, midline shift, ICP over 25, intraoperative brain swelling, young patient, Glasgow 5 to 8. These are the patients that we're mostly confident can be treated with decompression with good perspective of recovery. On the other hand, a patient with brainstem injury or diffuse axonal injury, or in elderly, or with the Glasgow 3 to 4, these are not good patients for management. So the decision about secondary treatment like decompression must take into account the ethical issue, and the neurosurgeon have to do in collaboration with intensivists and neurologists and with the families. Whenever possible, we need to respect the pre-injury willings of our patient. this is an Australian study. They asked the relative of patients which were decompressed, were you warned regarding possible survival with patient disability? And as you see it here, most of the cases, they were not awarded. They were not awarded about the possibility of a bad outcome. So first of all, we need to talk to the families. We need to tell them that in long terms, surgical decompression may work, and we have to explain them the pro and contra of the operation. And we need to go with what Martin Smith has written at the end of the rescue ICP study, where you see that we recommend decompressed craniotomy. The decision must always be taken not only in the context of his clinical indication, but also after consideration of an individual patient preference and quality of life. So it is a mixture of a medical indication and an ethical indication together. But life is different. As I told you, the view of the decompressive craniotomy surgery is different. We were recently in an international symposium of the American Congress, and we asked the attendance of this symposium, which were about, in this room, about 400 people, mostly neurosurgeons from US, but some European. And we asked them, after this publication of these studies, did you increase the number of surgeries or you decrease the number of surgery? And almost all the American neurosurgery say we increase the number of surgery. But almost all the European neurosurgery say we decreased, including 3 authors of the rescue ICP paper that were there. So the views of how to work after the publication of these very good class 1 studies in the neurosurgical community still unclear. So we just finished inviting all of you to Naples, in my country, where in June we will have the International Congress of Recent Advance in Neurotraumatology, and it will be a nice Congress, and we will discuss many of the issues that we have touched today. Thank you for your attention.
Hello.
Hello.
Hi. This is Angelos. I'm not sure if Amro is there. Amro is the WFNS YN chairman. I'm the vice chair. Amro, can you hear? If not, I would like to say a huge thanks to Dr. Servadei, the WFNS president, for giving this inaugural, the first webinar in the WFNS Young Neurosurgeons webinar series. I think that this was a fantastic presentation, which really shows what the WFNS should be striving for, which is to increase the access to essential neurosurgery worldwide. And I think with this talk, this is what Dr. Servadei has really done in a very eloquent manner. I think we probably have some time for a few questions. Is that okay, Dr. Servadei? You have some time to take some questions?
Yes, 5 minutes, then, okay.
Yes.
No.
Ahmed, have you collected any questions from... have you managed to collect any questions?
The floor is open now for if anyone wants to ask a question, so he can raise his hand. So we can take a question. So if anyone from attendee want to ask a question, please raise your hand and we will give you the chance to ask the question.
Any questions, anyone?
So far, we are so far no one is asking. We have Dr. Hissam Al-Jahani saying thank you. Difficulty to provide cranioplasty after decompressive craniotomy in Brazil. This is a question from, or a comment from Dr. Wagner.
Yeah.
So he's asking, difficult to provide cranioplasty after decompressive craniotomy. Any idea to change this reality?
I can see the questions. I changed the reality. The question is the people who are running healthcare in Brazil, like in my country, is the same. There are many of them. They are very keen of showing the people and the public and the youngs and the politicians and everywhere that we can cure patients. At the beginning, during the acute phase, they don't care very much about what we do later. When the life is saved, they think that the money is gone. We don't need any more support. Actually, we need to reconstruct a young guy with a big hole in the brain. Even if his life is saved, the quality of the life is very bad. So what we have to show our politicians and the people who is running our countries is that we need to cure these patients from the beginning to the house where they live. We cannot leave them something in between. We had the same problem. We had a few years ago, we had to fight. Now the fighting is finished and we got the money, but we have to fight to get the money to appropriately reconstruct the vault, because they saw these patients are cured. Why do you need more? So I agree with you. In Brazil, the high cost of materials is very high. I mean, basically 3D reconstructed cranioplasty are very expensive, at least are expensive. We have tried to save the bone and store the bone in the refrigerator, but we know that 30% of these bones will not be effective, will be rejected. Then we have tried to put the bone in the abdominal punch, but there are conflicting papers showing that sometimes is reabsorbed. So probably the best is an heterologous cranioplasty, but all the types of cranioplasty we have, from titanium to PMMA to PIC to hydroxyapatites, they are all expensive, I know. So, but the people have to understand, if you spend $200,000 to save the life of a patient, how can it be possible that you don't have $5,000 for the reconstruction?
Yeah.
This is something that it has to go to the politicians and to those who are really following us. Then I have a question about ICP monitoring. As I have shown, and as the group in Cambridge has written, whenever you need to decompress a patient who is in your ICU, and for instance, with multiple contusion, and you don't know actually what to do, ICP is fundamental, because you need ICP to understand if the medical treatment you are doing are effective or not. So in secondary decompression, I think ICP, whenever is possible, because there are countries in which it's not possible, whenever possible, it's mandatory. For secondary decompression. For primary decompression, no, because you will operate the patient because of the acute subdural hematoma, and you will decompress the patient as a preventive measure. So you don't need it really. But I think it's extremely important to understand these two different scenarios. Angelos is part of the group in Cambridge, and he knows very well that the scenario is totally different. That's why we are now having the rescue SDH, which is separated from the rescue ICP, because they are two different things. And then we have a question who is very, very much important.
Dr. Servadei, sorry, before we go to the question about AIDS, on the issue of ICP monitoring and craniectomy, if I may ask just another question, what is your opinion about the use of craniectomy in settings that they do not have routinely ICP monitoring because of high costs? Many countries, many developing countries do not routinely have ICP monitoring, as you know. So in those settings, can a craniectomy be used earlier, even without a subdural? It may be somebody who has contusions, for example. So a young patient with a GCS of 9, 10 contusions and no availability of ICP monitoring. What is the role of craniectomy in that setting?
I think we have seen, as I've shown you one paper from Nigeria, is a matter of fact. This is an indication in these countries. If I had the possibility only one CT scan, if this CT scan has multiple contusions, the guy is young, the clinical conditions are good, and I have no ICU, then, I mean, a preventive decompressive craniectomy will help the patients to improve. That's clear. So I agree with you. The conditions are different. And there is a question about, there is another question about separating patients who are treating with us, meaning older patients with fall as a cause of trauma, and patients younger with road traffic accident. That's what I'm telling in my presentation. These two conditions are totally different. So the group in Cambridge now have moved to include patients in countries like India, where the subdural hematomas are an endemic disease. And this is extremely important, that whenever we can, we extend, I don't say only clinical studies, but data collection in countries where the situation is different from the countries in which there is papers publication. This is extremely important. We need, if we wanted to help to increase the quality of care, we need first to know about what's going on in these countries, which are the results. So I discover from many papers from Nigeria and Ghana and Cambodia that the situation is improving. So the people is trying to improve the management of traumatic brain injury with little resources. We just have to go into this and do it better. I have still time only for one question.
So there is one question about AIDS and whether there is an AIDS threshold, in your opinion, about craniectomy.
Unfortunately, the age, as you know, Angelos, as all of us know, the relationship between age and outcome in traumatic brain injury is linear. So it goes up. There is no magic number. And usually the number is older than you are. That's the number. So as me, I am a bit older than all of you. So my age limit is older than me. So I would suggest that over 75 years, even in Europe, there are very little chance that, at least in our experience, all the patients we included and decompressed over 75 years never recovered. So I think to be with a very limited support by evidence generated by papers published, I would say that somewhere between 70 and 75 is the limit. What do you think, Angelos?
But I think, you know, it's a difficult question. As you say, people's opinions are changing, even the doctor's opinions. And the other issue is that you have some people who are might be 75, but they are more fit compared to some patients who might be 60 and 65, because the person who is 60 or 65 might have several other medical problems. So I don't think it's just the age. I think it's the whole picture that we need to take into account. But, you know, you're obviously, you know, right that increased in age is associated with a worse mortality. There is no question about it.
Yeah.
Do we have time for just one more quick question? Because I think that's an interesting surgical question. Somebody is asking whether increased time in the operating theater when you do a craniectomy might be leading to a worse outcome. And in other words, do we need to be spending a lot of time to do a careful dural repair? Is that going to have any difference in terms of outcome?
No, it has been proved that it doesn't make any difference in terms of outcome. You know, Angelos is working in UK. I'm working in Italy. We are used to close the watertight dura always. In UK, they are not doing this. They are not used to close watertight dura,
No.
even in many other occasions. And we have put our case together in multi-center studies, and it doesn't make any difference. So
No.
we think that we have data to prove that the watertight closure is not mandatory. Probably it helps when you want to do a cranioplasty. Probably.
Yeah. So I mean, to answer this question from my point of view, what we tend to do in our practice is just an onlay duroplasty, using perhaps some like Surgicel or artificial dura, but we do not suture it. We simply leave it in situ between the dura and the temporalis muscle, and this facilitates the cranioplasty, but we never suture it. Yeah.
No, and the results are very similar, so I don't think it's an issue. Okay. Okay, very full of questions, and if you have more questions, you collect them and I can email them.
Brilliant.
Actually, Professor, we have many questions in question bar and also many questions in chats. Thank you very much for your time, and also for all those ask a question. We will collect them and we'll try to reply on them.
Okay, thank you very much.
Thank you very much for being here in this first webinar.
Okay.
Thanks a lot.
Thank you a lot.
Okay, bye now.
Goodbye.
Ambro, do you want to say a few words, Ambro? I think we can let Professor go. Do you want to say a few words, Ambro, or in terms of the next? Yeah.
Ambro?
I'm not sure if Dr. Ambro is around. I think he have connection issues.
Oh, I see. Okay.
Is around.
Okay.
So, if not, no worries. Thanks very much, everyone. And we look forward to seeing you in the next webinar, which will be announced soon in the next few days. Thank you very much. Bye, everyone. All the best.
For the attendee, you can subscribe for our channel to see the whole lecture uploaded online in our channel on YouTube. And also we have your data and information, so we can announce for the next webinar for anyone who is interested to join us. More than welcome, and thank you very much for attendance.
Thank you. Thank you.